session. So I would like to invite Dr. Vipul Nautiyal, who is professor at Shri Ram Himalayan University, Dehradun. We have Dr. Pawan Mehrotra, who is assistant professor at SRMS MS Bareilly. Dr. Manoj Sharma, who is a senior consultant at Action Cancer Center, Delhi. Dr. Kisle Dimri is a professor at GMC, Chandigarh. Dr. Piyusha Kulshrestha, who is a senior consultant in Metro Hospital, Delhi. Dr. Vinod Nimran, who is director of Indus Super Speciality Hospital, Mohali. Dr. Dodul Mondal, who recently joined associate director at Max Saket, Delhi. Dr. Subhash Gupta, who is a professor at AIIMS, Delhi. And Dr. Rashi Agarwal, senior consultant at Max Hospital, Vaishali. So with so many radiation oncologists and no surgeon, so I think feel free to say whatever you want to say in favor of radiation. So now let me just, the topic is how to deal with the radio recurrent disease after radiation in a biochemically recurrent CA prostate. So the problem is that 1/3 of patients, they undergo radiation and nearly 40% of them have intermediate or high risk disease. And in fact, in patients, even if they have been treated with 78 gray, the 10-year biochemical recurrence rate is 10% in a low risk disease, 23% in an intermediate risk disease, and to the tune of 44% in high risk patients. And the biochemical recurrence precedes the development of distant metastasis and death due to prostate cancer by 5.4 years and 10 years respectively. The problem is 40 to 60% patients will have biochemical failure, and 25% of these will have disease progression within 5 years. 3 to 10% of patients will have local failure only after radiation, and so local salvage may be curative. So this is the group that we are talking about. But unfortunately, most people are treated with observation or ADT, and only 2% of failures after radiation are managed by local salvage. Rest all are treated by ADT. So this figure we have to improve. So that is why let's talk and go back to the case now. So this is a 65-year-old gentleman who has diabetes, hypertension, CAD, and he presented with complaints of rising PSA. He had earlier received external radiation, conventional radiation, 78 gray in 37 fractions, because he had a TURP earlier. And he received short course ADT 2 years back. The previous histopathology was, of course, adenocarcinoma. His index PSA was 8 nanogram per ml. Gleason score was 3 + 4, 7. And IPSS score was 14. It was a CT2B N0 M0 disease. And now he has a gradually rising PSA. The current value is 0.3. So my question to Dr. Vinod, how do you define biochemical failure, Dr. Vinod? Is Dr. Vinod there? Hello? Is Dr. Vinod there? So if Dr. Vinod is not there, I would request Dr. Pawan to please take this question.
Yes, ma'am. Good cause for the resident. This is a very good question, how to define biochemical failure, because initially we used ASTRO guidelines which use 3 consecutive rise in the PSA values, but now there was a conference in Arizona. Phoenix criteria has now been used, in which we use value exceeding from the nadir by 2 nanogram per ml.
So that's very rightly said. So I think first of all, we have to understand what do we mean by a biochemical failure, because biochemical failure post-radical prostatectomy is different and post-radiation it's different. So I think Dr. Pawan clarified that very nicely. So coming to the next question. So if we know that there is a biochemical recurrence, which imaging modality will you use in case of a biochemical recurrence? Would it be an ultrasound pelvis? Would it be a bone scan? Will it be an MRI, a conventional MRI, or a multi-parametric MRI, PSMA PET scan, FDG PET scan, or a choline PET scan? Dr. Piyusha, can you take this question, please?
Yeah, yes, ma'am. I think choline PET is much better than PSMA PET scan. But as choline PET is not available everywhere, so I should go with the PSMA PET scan. it is better because we have to rule out the metastatic disease also to look into the whether we should treat the patient locally or we have to treat with a metastatic disease. So we have to rule out the metastatic disease. We should go for PSMA PET scan first. Once we rule out the metastatic disease, then we go for multiparametric MRI to look into the local disease.
Okay, I think very well said. Dr. Manoj, would you like to differ or do you agree to the same? Dr. Manoj? Dr. Vipul, would you take this question?
Yeah, as ma'am said that it depends on the availability and affordability of the patient. Because the biochemical failure means the patient is having very small volume disease.
Yeah.
So the choline PET, or if not available, the PSMA PET would be the choice to detect the small lesion if he have.
Yeah.
Can I add, ma'am, something?
Yes, please.
Ma'am, because in many studies they have quoted biochemical failure is not mainly associated with the recurrence in prostate and anywhere. Many patients we can see biochemical failure is there, but metastatic prostate is not there. We should certainly go for PSMA PET, which is available in our setup normally. We should go for PSMA PET.
Yeah, so definitely, I think, so let me go and show the sensitivity of these various procedures. Nobody for bone scan. So actually, if you see that if the PSA is less than 10, then bone scan will detect only 2% of the lesions. If the PSA is between 10 to 20, it would be 5%. And if the PSA is more than between 20 to 50, then bone scan would detect 16% of the lesions. The beauty of the PSMA PET is that even if the PSA is less than 0.5, it can detect close to 40% of the lesions, and which is usually the case in a biochemical relapse. So which would otherwise have been missed. And if the PSA is between 0.5 to 1, then 57% lesions would be picked up by PSMA PET. So PSMA PET has a high specificity, sensitivity. And if you talk about MRI, then if we do only T1, T2 images, then we may miss these lesions. So it's always better to do a multi-parametric MRI, which also has a functional component to this. So as we know that in the peripheral zone, there is cancer. So diffusion weighted images and ADC map would be helpful. And for transition zone, T2 weighted images would be very, very helpful. So post radiation, there is a decreased T2 contrast in the periphery due to gland atrophy and fibrosis, and there would be decreased vascularity. So, but in a recurrent lesion, there would be a neovascularity. So this would be picked up by a multi-parametric PET scan. So ideally, whenever possible, we should combine as Dr. Piyush also said, that we should combine multi-parametric MRI plus choline PET, because FDG PET is suboptimal for these lesions and we don't have the availability of choline PET. So these are the various sensitivity and specificity of various parameters, and we must see that truss-guided biopsy also picks up lesion if the PSA is more than 2. So it's very, very important to choose your imaging modality well if you want to detect the lesions. So Dr. Dodul, now this patient has come to you. Will you send this patient for ADT, or what will be your preferred approach for this particular patient who has a biochemical recurrence only?
So if it is a biochemical recurrence, then I would like to go ahead with a so it's a biochem, so PSA is high. So I'd like to go for a biopsy before deciding any treatment, and then we'll also try to evaluate the life expectancy of the patient with available nomograms.
Okay. So this patient had a radiation 2 years back. So would you send the patient now for biopsy, or you would like to wait?
So after 1 year of radiation, so within 1 year of radiation, I'll definitely not send the patient for biopsy because there are a lot of false positivity within this time. Now, if the PSA is less, so it is with less than 2 as of now.
It is 0.8. This is
so it's less than, so it's even if we say that the nadir is 0, then also it is within 2, not more than 2 nanogram per ml. So I will like to wait if the biopsy is negative, and it's only PSA is 0.8. So I will not start treatment right away. I will observe.
Okay. So how will you decide when to start treatment? How long will you wait?
So we'll have to see the PSA doubling time and also the Phoenix criteria of 2 nanogram per ml over the nadir value. So definitely 0.8 does not classify that. Secondly, even if the PSA rise is less than 2 nanogram per ml over the nadir value, but the doubling time is high, very fast, then also the patient merits treatment. So if you see the recent NCCN guidelines also regarding this particular scenario, there are specific subset of patients where the nadir criteria of by Phoenix definition is not being fulfilled, but the doubling time is shorter. Then also we can start the treatment. And during that treatment, there are multiple options which you can discuss.
Yeah, we'll go to that. So why, so earlier, I think all of us would send the patient for ADT. So why not ADT? The problem of ADT after biochemical failure is that initial biochemical response, sorry, this is not relapse, but response to ADT is almost universal, but median duration to response is only 24 to 36 months. And as I mentioned, this particular case has had diabetes, hypertension, CAD. And we all know that after ADT, there is significant morbidity and even mortality. And there is reduced testosterone recovery also, which leads to lesser quality of life. We will not go into further details of ADT now. So I want to ask this question to Dr. Subhash. Dr. Subhash, why do we need local control and local salvage? Why can't we just do ADT? And why is it, do you think it's very, very important for us to have a local control?
Dr. Indu?
Yes.
See, first of all, whenever we are deciding a treatment, we have to think of it that most of these patients will have before they present as METs, there will be a period of approximately 5 to 6 years. Yeah. So there will be a gap of 5 to 6 years before they present as metastatic disease. So biochemical recurrence is just, it tells you that the disease is going to come after maybe 5 years, maybe 6 years. So these are the patients, if we start ADT, that's a lot of side effects. Some of them have cardiac comorbidities, diabetes, hypertension. So there's no point in starting this ADT upfront. So if there is only a local disease on PSMA, non-metastatic disease, then we can, which can be salvaged by either a radical prostatectomy or other options, then that is a preferred option initially with a biochemical recurrence. So we have to see that what quality of life we are giving to the patient, because that is the most important to the patient, rather than opting out, giving him the treatment and decreasing his PSA levels. So that should not be our initial thinking. Exactly.
I think very rightly said, Dr. Subhash, because it has been seen in a study by Pugs et al. That if 15-year distant metastasis-free survival with local control was 77%, compared to only 24% with local failure. So local recurrence is the source of distant metastasis. And in fact, Zaleski has also pointed out that in patients treated with initial RT, those with negative biopsies had 10-year biochemical relapse-free survival of 59% versus only 3% for positive biopsies. So there is something which is called as seed. So the local failure may seed distant metastasis, and it may lead to a second wave. So that's why it's very, very important to treat the index lesion. And as Dr. Subhash rightly said, that when the biochemical relapse occurs, for the distant metastasis or disease to actually progress, it may take 5 to 6 years. So there is no point in giving ADT and worsening the quality of life of the patient. So Dr. Kisle, I would like to ask you this question. So how would you manage this patient? Would you just observe? Would you do radical prostatectomy? Would you do a cryoablation? HIFO, Sbrt, brachy, low dose rate, high dose rate? What would be your preferred modality and how would you decide that?
First of all, we need to make a decision whether we need to treat this patient or not.
Yes.
So for that, we need to take multiple factors into consideration. For example, because there is a phenomenon of PSA bounce also, which is a transient decrease in PSA, which may occur at 12 to 18 months after completion of radiation. So that also needs to be, because the PSA levels are not in the as per the Phoenix criteria. So first of all, I need to and also we need to look at that PSA doubling time. So if things are in favor of, for example, if the PSA doubling time is short, and if if the serial PSA levels are in the increasing trend, then I would definitely like to treat this patient by one of these modalities. And in this particular patient, I would prefer giving some local form of therapy to the patient, which could either be in the form of either radical prostatectomy or maybe cryoablation.
Okay. Dr. Manoj? Dr. Manoj?
He is not here.
He's not here? Okay. Anyone? Dr. Ashi, would you like to take this question? Dr. Subhash?
Yeah. So first of all, Dr. Indu, in this case, we have not fulfilled the Phoenix criteria of a biochemical recurrence. So the total PSA is around 0.3. So we have to see what is the doubling time. If the doubling time is less than 6 months, then only we'll proceed for any kind of a local treatment in this case.
Exactly.
And before jumping to radical prostatectomy, we have to see the initial values also and the current values of PSA. Like if PSA is less than 1, and then we will do a biopsy and see the Gleason score, whether the Gleason score is low or the Gleason score is high. If the Gleason score is high, then probably radical prostatectomy failure rates are also very high. So we have to consider all these factors before taking any local treatment in this patient.
Yeah. So I would
very rightly
ask
said.
Vash, Dr.
Can I just add one more comment to this?
Yes, please.
So if we see the treatment paradigm in biochemical recurrence, a very important factor is life expectancy, and that is true for entire treatment protocol for CA prostate. So even on recurrence, if the patient is having a life expectancy of less than 10 years or more than 10 years, that makes significant difference in decision making. So if it is a less than 10-year life expectancy, then the patient can well be put on observation.
Dr. Rashi also wants to add.
Dr. Dodal. Yeah, okay, I'll involve her. Dr. Dodal. So now I think the criteria for life expectancy, which was there for 10 years, has been there's still no consensus whether you should take life expectancy as 5 years or 10 years for Sbrt or for brachytherapy in both the studies. Before we go into that question, I would like to ask Dr. Rashi. Dr. Rashi, this patient is post-radiation 2 years. So do you think that if we do a biopsy now, it would give us the true answers that we are looking at?
Yeah, Dr. Indu, after 2 years of radiation, it will be difficult to get an answer. So it is possible, it can come false negative. It is possible. Actually, you have already mentioned, yes, it is a very difficult case. And I think I have not treated, I honestly accept I have not treated such type of patients, and I would have sent this patient for ADT. And I also want to thank Dr. Manish. So I also read about this, what is happening. And so, I am not ready for the radical prostatectomy. I don't want to give a brachy. Yeah, we can do Sbrt, but it is very important. Just already all has mentioned, Dr. Dodal and Dr. Subhash. We should prove it, I think, what I could understand.
So let me tell you about the problems of biopsy at this time. I mean, some people say that we should wait at least for 3 years because there is no point in doing a biopsy within 2 years of radiation because number one, because of altered architecture from previous RT, so it would be difficult to see the Gleason score. And RT effects may mimic a high-grade lesion. So it may not actually be a high-grade tumor, but it may look like a high-grade lesion. And 30% of lesions which are indeterminate or we think to be positive may turn out to be negative. So, and some patients may have a delayed radiation response even after 2 years. So, and another point is that definition of clinically significant cancer differs between studies ranging from Gleason score 6 to Gleason score 7. And some people say whether we should see cancer core length more than 3 millimeters. So there are so many unanswered questions. Some people, brachy studies that recommend a biopsy, radiation studies that don't all say that biopsy is a must. So this itself is a gray area, whether we should, how much we should consider biopsy also.
Dr. Indu?
Yeah.
What are the other findings of these patients, the MRI finding or the PSMA PET findings?
Okay, so
Have you investigated this patient?
So actually, this is a hypothetical patient. So this patient doesn't exist. I have not treated any such patient. So I don't. That's why I could not
So
see any
they are
images.
just dependent on the only the PSA findings.
So I mean, if we hypothetically assume that maybe because this PSA is only 0.8, so MRI is showing a locally multiparametric MRI is showing a very small focal lesion. That's what it's not being picked up on a PSMA PET also. So it's a locally confined disease picked up on a multiparametric MRI. So these are this I just wanted to just show this slide because this was a systemic review and meta-analysis of local salvage therapies after radiotherapy for prostate cancer. This was a master study where they have shown that whether you do any of these options, radical prostatectomy, cryo, HIFO, SBRT, HDR or LDR, the 2-year relapse-free survival ranges somewhere between 50 to 70%, 50 to 80%, which is almost the same. 5-year relapse-free survival is somewhere to the tune of 50 to 60%. With radical prostatectomy, severe GU toxicity is very much high, which is to the tune of 21%, and so are with cryo and HIFU. SBRT or brachytherapy, they lead to less GU toxicity. Similarly, the GI toxicity is also higher with radical prostatectomy, cryo or HIFU, and they are very much less with brachy. Urinary incontinence is very much high with radical prostatectomy, and so is it's high with HIFU. And almost 90% of the patients will have erectile dysfunction with radical prostatectomy and with cryo and HIFU. So they concluded that there were no large differences in 5-year outcomes when comparing all salvage treatment modalities against radical prostatectomy. So these re-radiation with SBRT, HDR or LDR appear to result in less severe GU toxicity. So now I want to come to but the problem is that although there were 150 studies and it were reported on 322 patients, but if you see the number of patients, there's only close to 2,500 patients for radical prostatectomy, 5,000 patients with cryo, SBRT only 261 patients, and for brachy this is close to 600 and 800 patients. So we don't have much data on SBRT. We still have don't much data on SBRT. So with that, I would like to ask Dr. Kisley. Dr. Kisley, suppose it's confirmed that it's a biochemical recurrence and it's more than 3 years post radiation, would your treatment decision change? Would you think differently?
So, mean in terms of approach,
if it's a biopsy confirmed recurrence,
okay.
So and the lesion is detectable on MRI. So what would you do?
So
how would you decide? How would you decide what treatment to offer to the patient? Are there any deciding factors for you which help you in making a decision?
Yeah, so basically, so the treatment which either we can offer this patient androgen deprivation therapy, or we can offer some local form of therapy. So that would actually again depend upon whether the patient initially was in the high risk category or was the lower intermediate risk category. So a patient who's in the high risk category, those patients and androgen deprivation therapy would be more appropriate. But this particular patient seems to be in the lower intermediate risk category.
It was in the intermediate risk, yes.
Yeah. So in this particular patient, we could definitely offer some local form of therapy. So again, it would depend upon the life expectancy, and it would also depend upon the time to this biochemical failure, the interval between
10 years is the life expectancy. PSA density is more than 6 months.
Okay.
Yeah.
So it is local therapy could I don't know much about this topic, but yeah, I think it could be some, maybe we can try, see the kind of literature that you had presented in the previous slide. I think based on that, this patient could be offered some form of radiotherapy, which could be either brachytherapy or SBRT.
See, there is some problem even with the literature. I'll come to you, Dr. Ashi. There's some problem with the literature. The literature mostly, I think, is mentioning about the patients which have been treated with conventional radiation and not with hypofractionation. So none of the literatures mentioned whether they would take the decision would be different for a conventional radiation versus a patient who has been treated with hypofractionation, which most of us are practicing now. So I think we'll have to look into that parameter also. Dr. Rashi, you were saying something. Yeah.
Yeah, can you ask in our panel if any of us has treated this type of patient?
Has anyone treated, Dr. Rashi is asking, has anyone treated any such kind of a patient?
Ma'am, I would like to add, we have treated a couple of patients.
Yeah.
SBRT, Dr. Shyam, by SBRT.
Yes. Yes, with SBRT. We have, yes.
So that's what,
SBRT.
yeah.
We are just waiting for the next session to listen on that.
Yes.
That's why we want to listen Dr. Shyam after this.
Yes.
Ma'am, can I add something?
Yes, please.
We have seen some patient, but not post-RT. Post-radical prostatectomy, biochemical recurrence, we have seen.
That's a common thing.
That's a common thing, but not these type of patient.
So we radiation oncologists are doing our job better than the surgeons, it seems.
Yes.
So let's all pat our backs. So I think Dr. Manish would ask me to stop in another few minutes. So let's, I'll just, I'm not going into the details of these slides, but so Dr. Pavan, I would like to ask you, in which patient would you prefer salvage prostatectomy?
So ma'am, I am a radiation oncologist and better that can be given by a very good surgeon. But as Dr. Dondal has said, we should always see, we should have a balance between the goal of cure and preservation of quality of life of the patients. Yeah. As this patient has a cardiac morbidity also, I will certainly not go for radical prostatectomy. But if some patient with no more comorbidities, with no lymph node involvement, initial stage, pre-treatment stage was T1 or T2, as this patient with no cardiac morbidity, I certainly go for salvage radical prostatectomy. That will help much better for the patient, except for some few side effects which already you have told us. Some fistula formation, urinary incontinence, and patient should have at least a life expectancy of more than 10 years. PSA level, some study have shown less than 10 nanogram per ml, Gleason should be 7 or lower than 7. As you have already told, no lymph node involvement, initial stage should be T1 or T2. Yeah. That patient can be put to salvage.
So I think these patients get a better benefit from radical prostatectomy, because we have to understand that the risk of the post-radical prostatectomy toxicities are very, very high. Urinary incontinence, impotence, anastomotic strictures, bladder neck contracture, rectal injury, rectovesical fistula. So we have to always consider these parameters also into account. This we have discussed, so I'll skip to the next slide. So there was this paper, which is a very interesting paper recently published. This is an ASTRO-ICROP consensus guidelines on salvage Sbrt for intraprostatic relapse. So there was the green things that you see, there was an agreement on these parameters, but there was not much agreement or less agreement on the yellow and red scores. So they said that Sbrt can be done if there is no age limit. Exclusion for life expectancy is less than 5 years. 10 years ka nahi hai, this is less than 5 years. ECOG should be 0 to 1. Previous ADT is not a contraindication, but patients should not be delivered concurrently with radiation. There was no consensus on these parameters. Maximum acceptable T classification at primary treatment, Gleason score at primary treatment, acceptable PSA at primary treatment. There was no consensus reached on that. So IPSs should be less than 15. This is important. Acceptable PSA at salvage treatment should be less than 20, which is important. And maximum Gleason score at salvage treatment should be 9 to 10. We don't have any Gleason more than this. Then we should, then there is a lot of controversy whether we should treat the whole gland or we should treat focally. That is also a lot of controversy for SBRT, also for brachytherapy. I think Dr. Sham would clear that. And re-radiation of seminal vesicles is not a contraindication. Metastatic disease should be evaluated and it should be done. Choline PET is, they have said it is preferable. Number of biopsies at recurrence for whole gland should be between 12 to 18. And for partial gland also it should be between 12 to 18. So Phoenix definition of biochemical relapse is valid for retreated patients, and primary treatment dose should always be considered when deciding salvage SBRT dose. SBRT dose should be higher respect to the primary treatment dose, and the EQD2 should be alpha beta 1.5. It should be more than 35 in 5 fractions. Dose should be prescribed at isodose line with a percentage of less than 80%. Recommended is 35 in 5 fractions, and these are the various dose schedules, which I'm not going into details because Dr. Sham will cover that question. So there was this article which was published in 2018. I just want you to focus on the conclusion that they gave. They said it's not a SBRT is not a standard of care and should not be considered for routine practice. Administer with caution in competent centers because we don't have long-term data of the toxicity of SBRT as a salvage treatment. So biochemical relapse-free survival in 3 years was 55%. Median PSA neither. This also we should remember that the PSA comes down 2.5 after roughly 10 to 12 months after SBRT. So we should not hurry up and counsel the patient that PSA will take some time to come down. GU grade 3 toxicity, grade 2 is only 8%, grade 1 was seen in none of the patients. And this was a very, very interesting article published by Fuller et al., where they did something like HDR brachytherapy and they gave SBRT. So what they did was that this you see that the red zone is the higher zone where they give, this is 150% isodose line, and the white one is the 125% isodose line. And they did a central periurethral isodose pairing to prevent urethral strictures later on. And also this yellow line, so the prescription isodose was not beyond adjacent bladder and rectum. And they also said that if the PSA at salvage was less than 6.92, then 5-year biochemical disease-free survival was 78%. But if it was more, then it was only 12%. So I think it's very, very important to decide early when to treat these patients, because if you treat them at more than 7 PSA, then even if you do SBRT, your results will not be so good. So now coming to brachytherapy. Dr. Vinod has joined, or he's still here, is not there?
Ma'am, we are about short of time.
Okay, so let me just go to the conclusion slide, then I'll not discuss any of these things. I'll send this presentation to all my people. Just a word about cryo. So cryo, what they are doing is that they are creating a lethal freezing temperature of -40 degrees centigrade in the prostate lobe containing the cancer. So the problem is that here in the urethra, they create they use a urethral warmer. So that is why if any tumor is present close to the urethra, that will be missed by focal cryotherapy. So this is an important point which I wanted to bring into notice. So it is less suitable for apical and periurethral region. Best is for Gleason less than 8, PSA less than 10, T1C or T2, or a low risk disease. In a HIFU, what they are doing is that in this, the probe is through the rectum. So if there would be any pathology on the rectum, any pathology, say rectal pathology, rectal stenosis, anal canal stenosis, inability to introduce the probe, inability to inflate balloon, bowel incontinence, severe hemorrhoids or toothed rectal wall, then you will not be able to do a focal HIFU. And if the PSA, the prostate volume is more than 40 ml, then HIFU is relatively contraindicated. So in these cases, you should do TURP if there is obstructive middle lobe lesion or intraprostatic calcifications or abscesses. So focal HIFU, they say it is suitable for all patients. Primary, even in a primary setting, if the life expectancy is less than 5 years, medical comorbidities are there, and no patient is not suitable for radical prostatectomy, it's a low volume, low grade tumor and PSA less than 20. It can be used for salvage, for advanced prostate as neoadjuvant debulking procedure, and also as for castration resistant prostate cancer. So this HIFU is better for a posterior lesion, while cryoablation is better for an anterior lesion. For apical lesions, brachytherapy is better. So this, I will not go into detail. So in this, what you are doing is you are using ultrasound energy, which causes thermal, increases the temperature by 70 to 100 degrees centigrade, and it leads to cavitational effects in tissue, leading to coagulative necrosis. And necrosis in the lesions in the focal point removed from the rectal probe. So here you have introduced the rectal probe, and this is how you are creating coagulative necrosis. So if the lesion is very far, say more than 25 mm or very anterior lesion, then HIFU will not be possible. So now I'll just, this is my concluding slide, and one more. So if a patient presents with a biochemical recurrence, PSA neither PSA plus 2 nanogram per ml after primary radiotherapy, do a PSMA PET or multiparametric MRI. And if it's a localized recurrent disease, then you see for any post-radiation toxicity. So if the patient has residual toxicity more than grade 1 or 2 from previous radiation, then Sbrt or brachytherapy will not be a very good option. If the tumor stage is less than T3B, PSA less than 10, PSA density more than 6 months, and interval between primary treatment recurrence is more than 2 years, only in these cases you should give a local radiation. So for these cases, focal salvage cryotherapy is less suitable for apical and periurethral lesions. It is better for anterior lesions compared to HIFU. Salvage HIFU is less suitable for anterior located lesions, and this cryo might be better. For brachytherapy, location is not a problem. You can treat in any case, but of course you have to respect the periurethral doses. Sbrt gives higher integral dose to healthy tissue, so PTV margins are necessary to compensate for intrafraction motion. We don't have too much data for Sbrt, but this is an evolving field, and I'm going to learn more from Dr. Shyam in this area. So post-treatment 10-year follow-up, at least PSA monitoring, toxicity and quality of life assessment is must. In case of biochemical recurrence, do a PSMA PET or multiparametric MRI. And in metastatic disease, do hormonal treatment or Sbrt to the metastatic site. So my take homes are multiparametric MRI with PSMA PET is mandatory for disease localization. Do biopsy preferably after 24 to 30 months of first radiation. If patient has a high Gleason more than 8, PSA more than 20, more than T3B disease, treatment a free interval between previous radiation.
Sorry,
and
Dr. Indu,
2 years.
please
Last slide.
wrap up the session, please.
Last slide. So then we have to offer ADT. RP, radical prostatectomy, has best results till date, but it should be done, has more toxicity, so it should be done for a younger patient if RT interval is less than 2 years, and if you cannot give radiation because of previous RT toxicity. If the patient has not received previous brachytherapy, then HDR brachytherapy may be done if PSA is less than 10, Gleason less than 10, IPSS less than 15, PSA density more than 6 months, and previous RT more than 3 years. Sbrt, if previous RT more than 3 years, no grade 2 or GI toxicity, PSA less than 10, Gleason less than 8. HIFU, if there is a posterior or periurethral lesion and prostate volume is less than 40 mm, life expectancy less than 5 years, and avoid if there is any rectal pathology. Cryotherapy, if anterior lesion, avoid if apical or periurethral lesions. So PSA bounces if RT-PSA, post-salvage RT-PSA is more than 0.4 ml at 1 year or 2 consecutive rises. So this is a biochemical failure after salvage treatment. I would like to stop here and I'll stop sharing my screen. I would like to thank all my panelists for a wonderful discussion, and Dr. Manish for giving me the opportunity to read on a very tough topic. Thank you so much.